Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss about a cardiac failure case.
Yes.
A 45-year-old female patient was brought to ER with complaints of breathlessness since last 3 days. Initial 10-second assessment, patient was conscious, oriented and obeying commands. Her airway was patent. There was no pooling of secretions, gurgling or stridor. Breathing, she was tachypneic with a respiratory rate of 25 per minute and saturation was 93% in room air, and there was bilateral crepitations. Circulation, her heart rate was 113 per minute and blood pressure was 190 or 115 millimeters of mercury. Okay. Now all peripheral pulses were equally felt bilaterally, and she also had raised JVP. Disability, her GC.
Raised JVP can be seen in which all conditions?
Right heart failure can be there.
Okay.
Or corporal like conditions.
It
Fluid
is a
overload.
right heart failure.
Fluid overload.
Volume overload is a condition wherever you get raised JVP in ER, we have to suspect volume overload condition. Other than volume overload, if without volume overload, can you get elevated JVP? Neck vein distance.
Obstructive shock. Obstructive. Cardiac tamponade.
Okay, there also you are getting a cardiac failure. Cardiac failure. SVC obstruction is one condition where the patient is having raised JVP without any volume overload. Yes. How do you detect that type of JVP from the cardiac failure JVP? How do you diagnose? A JVP elevated due to SVC obstruction, JVP elevation due to cardiac failure or volume overload. What is the difference?
The respiratory variation. SVC it will be persistently elevated, but there will be that hepatojugular reflex.
Hepatojugular reflex is a condition where there is minimal cardiac failure. When you press, it is elevated and persistently elevated.
With the changing position, it won't change.
If there are no waves in JVP, then it is more in favor of obstruction.
Yes.
Obstruction will not, because waves are produced basically from the heart pressure changes. That is occurring only when there is a connection from the venous vein to the cardiac chamber. If that is blocked, then you don't get it. So non-pulsatile JVP, once you see that is a sign of SVC obstruction. Okay.
Exposure, her temperature was 98 degree Fahrenheit and GRB is 105 milligram per deciliter. So adjuncts, we placed her in proper position and we started oxygen. Her saturation was only 93%. So we started oxygen via face mask, and we by the time I asked the staff to arrange for an NIV. Then we took an ECG. ECG was showing sinus tachycardia. 2 large bore IV cannulas were inserted and we took an ABG. ABG was showing a pH of 7.46, PCO2 of 29.4, bicarbonate of 19.6 and a PO2 of 59. Respiratory alkalosis with PO2 of 59.
Okay. What is the cause for respiratory alkalosis?
Maybe because of the pulmonary edema.
Okay. Type 1 failure.
Type 1 failure.
Okay.
SO2 and lactate?
SO2 was 92, in that a lactate was 1 and so other electrolytes are normal, and hemoglobin was 12.
Okay, anxiety itself can produce. Okay.
So we asked for a chest x-ray and we did a bedside ultrasound. It was showing bilateral B lines and her inferior vena cava size was 2.1 centimeter with less than 50% collapsibility.
Okay, that means what?
That means that she is in volume overload.
Volume overload situation. Okay.
And we, by that time we did a point of care CBC CRP to differentiate because B lines and all can be seen in bilateral pneumonia, ARDS and all. So we did a CBC. Total count was only 9,000 with a hemoglobin of 12.8. Platelet was 2,60,000 and CRP was 8.
Okay.
So unlikely to be an infection.
Okay.
Since she was in volume overload, we gave her furosemide, 40 mg was given and followed by an infusion. And since her blood pressure was high, we started her on NT.
How will you decide on the dose of furosemide in patients like this?
If this patient is already on furosemide, like 80 mg BD and all, we will have to give double dose. That means almost 160, 200 should be given stat, then we will have to give infusion. This patient was not on any fixed dose. So we gave only 40 milligram. Then ample history.
What is a BP change when you are giving furosemide? Is furosemide, there is a change in infusion or IV bolus?
If this patient is having a somewhat borderline BP or hypertension, we shouldn't give any bolus dose. We can directly go for an infusion.
Okay. Bolus dose can produce some amount of hypotension, but infusion normally it will not produce.
Ample history. There is no allergies. Patient is a para 2 living 2. Last childbirth was 20 years back. She has bronchial asthma since last 9 years. And she is on...
Is menstrual history important in this type of patients?
Yes, sir.
Why?
Young females, there can be dilated cardiomyopathy, postpartum cardiomyopathy, these things can
Okay. Anemia. Okay. Then what is the risk of coronary artery disease after menopause?
That increases.
Increases means what?
It will be more than a male of
Male.
the same age.
It is more than a same age male. That is a problem. So postmenopausal ladies are at a higher risk for coronary artery disease and cardiac related diseases. But premenopausal ladies, they have very, very less incidence of coronary artery disease. Okay.
So she was on deflaxocort, then she's on formiflo, that means formoterol with fluticasone.
Deflaxocort is started for
Asthma.
asthma.
She's on telecast and this
Telecast is montelukast.
and
Deraphyllin?
deraphyllin also.
Okay.
And she's also hypertensive for 8 years and she's only taking nebivolol for that.
Okay.
Last meal was on the previous day. Events was she had breathlessness this last 3
So
days.
asthma, nebivolol, any problem?
No, nebivolol as such doesn't
Okay.
have.
Your beta blockers like nebivolol, carvedilol, they are not that problematic like metoprolol or other previous generation drugs.
Breathlessness is last 3 days. Previously she used to have breathlessness last 2 weeks. It was like NYHA grade 2, but it progressed to grade 3 since the last 3 days.
How do you know that it is cardiac failure or respiratory disease? This patient is having asthma. How do you know that it is not asthma?
Diurnal variation will be there.
In emergency room. Patient is not able to talk. You are putting on BiPAP. How do you know that it is not asthma? It is only cardiac failure.
Peripheral.
IVC is
That's okay. Then
edema, any
Then.
features, JVP.
then JVP can be elevated in
We
severe.
give a nebulization if it is reversed.
Okay. Cardiac failure also will have some bronchoconstriction and can reverse. What is the investigation which can be done in ER?
BNP.
Can be
BNP. So we have to, this is the condition where you have a doubt like this, we have to utilize BNP. Otherwise BNP in a clinical settings where you exactly know this is cardiac failure, BNP does not have any role. BNP is designed to rule out non-cardiac Bs. Okay, so in emergency room we have to use it.
And she also has bilateral lower limb edema and she's also complaining of orthopnea and PND since the last 2 days.
Okay.
There is no history of fever, chest pain, abdomen distension, cough or palpitation.
You told the bronchial asthma background is there.
Yes.
Cardiac wise, anything proven in the past?
No.
Nothing.
Only hypertension and bronchial
Okay.
asthma. On reassessment, her heart rate was 89 per minute and respiratory rate was 16 with face mask and BP was 160 over 90.
Do you think that respiratory rate is correct?
She became, maybe because of the furosemide and all, she became symptomatic.
When she came, what was the respiratory rate?
25.
Okay, it has come down.
Both BP and respiratory are settled.
Settled after furosemide.
And saturation was 99% with 3 liter O2. So we could bring down the face mask to a nasal bronch and NIV was not required for her.
Okay.
And on examination, she had no pallor, icterus, clubbing cyanosis, lymphadenopathy, and she had bilateral lower limb edema. Then cardiovascular system examination, first and second heart sounds were present. There was no other murmurs or anything felt, and no S3 or S4 was had.
Okay.
And other system examination, respiratory system examination, bilateral crepitations were there. Other system were within normal limits. So we went ahead with the lab investigation. We sent for the BNP. It was 4,698.
Okay, that is high.
This female was only 45 years. So in 45 years, it is high, significantly high. This
Is BNP very specific or can be raised in other conditions also?
yes, BNP can be raised in other conditions like renal failure and all. It can be raised. Pulmonary embolism, renal failure.
What kind of BNP you did?
We did an anti-pro-BNP was done. Actually, pro-BNP itself is it is a precursor. It can be it is 108 amino acids are there, so it will go into BNP and pro-BNP. BNP is having only half-life of 20 minutes, so
Okay.
anti-pro-BNP has more half-life, so it is more it can be easily got. Then we went ahead with an other lab investigations we did. Simultaneously, we planned for a 2-day echo also.
Did you tell about the ECG?
ECG was showing sinus tachycardia. There was no LVH features.
Okay.
TFT was done. So we had to rule out any high output cardiac failure. So
Okay.
for that we did a thyroid
How do
function.
you clinically differentiate a high output cardiac failure from low output cardiac
They
failure?
will be having warm peripheries.
Okay.
Then
What are the causes for high output cardiac failure?
anemia, beriberi, wet beriberi, then thyrotoxicosis, pregnancy, then patients with AV fistulas and
AV fistula, only that area you get. AV fistula where?
neck.
Is it inside our body, lungs or somewhere, but not like a AV fistula. Peripheral AV fistula will not have any clinical finding. Beriberi, what is beriberi?
Beriberi thiamine deficiency. Basically, they will be. It will usually be seen in malnourished patients or in alcoholics.
Alcoholics.
It will be seen.
Okay.
So basically, pyruvate will have to convert into acetyl coenzyme A. That will for that thiamine is required. If that is not possible, this pyruvate will convert to lactate and all, and it will cause.
So, what type of cardiac failure is known in beriberi? What is a how do they have that warm peripheries? Alcoholic patient can have alcoholic cardiomyopathy. Thiamine like low thiamine induced beriberi cardiac failure. Both are possible. How do you differentiate both? So somebody can have alcohol induced cardiomyopathy. Somebody can have thiamine reduced induced cardiomyopathy. Why they have peripheries? Have warm peripheries.
Both.
How? Alcohol induced mainly left ventricular failure. Other one produces mainly right ventricular failure with peripheral AV fistulas. What you told is AV fistula, small AV connections will form. That produces warm peripheries. They have predominantly right heart failure. Other one will have predominantly left heart failure. Okay, but ultimately both can induce right heart induced left heart failure. Left heart failure can produce right heart failure. So clinically it will be very difficult, but warm peripheries, if an alcoholic patient come with a warm periphery with failure, then that is more in favor of thiamine deficiency. If they have typical left ventricular failure, then it is alcoholic cardiomyopathy.
Thyroid function test was normal, sir. TSH was 1.36 and T4 was 1.44. Renal functions were normal.
Okay.
Urea was 31, creat of 0.57. We also sent for the cardiac enzyme. The troponin was 0.012.
Okay.
And CKMB, CK was also normal. And we did a 2D echo. A 2D echo was showing concentric LVH with global LV hypokinesia and moderate LV dysfunction, which an ejection fraction of 37%.
Okay.
And there was no pulmonary artery hypertension, no other valvular abnormality, coarctation of aorta, and there was only trivial MR with trivial TR and only grade 1 diastolic dysfunction.
Okay.
It is more in favor of systolic failure.
Okay.
That was it, sir.
Okay.
So we shifted her to ICU. We continued her on oxygen.
So patient who is having systolic failure, means LV failure with high BP, how do you manage this case in ER?
So high BP can again worsen the LV failure because of the increased afterload. So we will have to give the NTG infusion or
okay, you have to dilate the peripheral arterioles. Yes. Then only heart can pump against that pressure. So how do you manage? One is Lasix you have started. That will reduce the volume overload on the left ventricle.
Then NTG nitroprusside can be started.
NTG can be started. Nitroprusside is not a good drug like this. Okay. NTG can be started because it has got action on both arterioles and venules. It can dilate both. Okay. What are the other drugs we can start?
Beta blockers.
Beta blockers are not a very good choice when somebody is failing like this acutely. It has to be started slowly. Even AC inhibitor also started slowly with higher doses. What other drug can be tried in acute medicine who is having cardiac failure with high BP? Dobutamine is not a good drug. It can be started. It is not a bad drug. It can be started. But what are the drugs we have which can give some relief in this condition? NTG is a very good choice. Something like NTG. There is any other drug? Huh? Hydralazine is one drug. Hydralazine can be started, but unfortunately IV form is not available. We have tablets, 25 milligram, 50 milligram tablets are available. We can start. How do you start beta blocker in this patient? That's a good drug, but no, it should not be given like somebody is having high BP alone. How do you start beta blocker?
Beta blockers is having advantage and both disadvantage is there. So beta blockers can basically inhibit the sympathetic action towards the low cardiac output state. So it should be started in lower doses. Should be started. So if we are giving it as a tablet and all, we will be giving it as carvedilol. If we are giving, we will have to give in a BD dose, and we will have to gradually increase
dose. What are the advantage? What are the actions of beta blocker in failing heart?
It will inhibit the sympathetic compensation towards this one, and if the heart rate is increasing, that will again affect the diastolic filling. So it can reduce the heart rate. It is having a positive inotropic action also.
Okay. Then AC inhibitors.
AC inhibitors are mainly used in a cardiac failure because of the renin-angiotensin mechanism. There will be more fluid retention and all. So that can be inhibited by AC inhibitors and ARBs.
So that can prevent ventricular remodeling.
Also.
So that these all drugs can be started, but in a graded way. But in emergency, we start Lasix, then NTG, hydralazine. If available, we can start. Okay.
NTG you told. How will you start NTG dose?
NTG 0.5 to 0.7 microgram per kg per minute. We can usually start as 5 microgram per minute, and we can every 15 minutes we will have to repeat the blood pressure, and we can increase it. But if we are starting it as a 0.3 ml per hour, we can increase to 0.6, 0.9 like that every 15 minutes. And we
will not be able to wait for 15 minutes. This patient is having failing heart. That is all in angina. Here we have to start
every 5 minutes go up on increase.
We have to act fast, because if you don't act fast, this patient will develop complete cardiac failure. So we have to do fast, and we have to reduce the BP fast. But whereas in angina, you have graded increase. Slow graded increase is okay.
To maximum 200 microgram per minute.
That is in hypertension. But angina, it is not that high dose.
How long you will continue NTG? Is there any problem in continuing for long?
NTG is having tachyphylaxis, so within 24 hours we will have to give change into oral medications, and we will have to stop NTG infusion. Then other complications are headache and
Here we have to change to oral medication.
Yes, sir. Initially we will have to start NTG infusion. Then
here in this condition, what you are telling, in this condition should we start oral sorbitrate?
No, her BP was getting control.
Here we are starting for BP control, not for angina. So oral sorbitrate will help only in angina, not in control of BP. Okay, but there is a concept that we can start anti-anginal drugs as a coronary vasodilators when there is cardiac failure. So triple drug therapy means you start beta blocker, you start AC inhibitor with like drugs like sorbitrate, which can improve the coronary perfusion. But it is not a clear-cut indication to start sorbitrate in a case like this without knowing what is the coronaries. Okay, we have not done any evaluation for that. Okay, from emergency room, we are starting NTG only to control the BP. To control the BP, we have to give another drug, not sorbitrate. Okay, how do you switch to oral drugs here? What are the drugs available which can be used as a oral therapy to control the BP here?
We can use hydralazine,
Okay,
beta
hydralazine
blockers,
is a very good drug. Beta
beta
blockers,
blockers, AC
AC
inhibitors,
inhibitors.
ARBs.
With
Diuretics.
which diuretic?
We can spironolactone.
Spironolactone. Ideal drug is
Potassium sparing.
potassium sparing diuretic, but they are weak diuretics, so we always add Lasix to that. Lasix with spironolactone.
Lacilactone.
Okay.
Any role for morphine in heart failure?
Morphine can actually reduce the blood pressure, and vasodilatory effect is also there. So we can give morphine also as IV 2 to 5, depending on the patient's blood pressure.
Okay. Blood pressure increases or decreases after morphine?
Decrease.
Okay, hypertension. So morphine can be tried in this patient.
This patient is having basically systolic heart failure, so we want to evaluate for why she is having a systolic heart failure.
Okay.
So most common cause of systolic heart failure can be an MI. So ECG wise, there is no ECG changes, or cardiac enzymes are also negative. Then other causes can be a dilated cardiomyopathy. Then there or any other valvular lesions like MR or AR can be other causes, or it can be because of any arrhythmias like tachyarrhythmias or even bradyarrhythmias also can cause.
Okay.
So that should be evaluated. So in this patient, we didn't get any actual precipitating factor for this.
Okay.
So we are planning her for a.
What are the causes for dilated cardiomyopathy?
It can be idiopathic, alcohol-induced, or any viral infections.
Okay. So viral infection is one of the common thing which can present with dilated cardiomyopathy. So that may be, if we don't know the cause, most of the time that is the cause. Okay. In pregnancy, postpartum cardiomyopathy is also common. Okay.
And some genetic causes also.
Okay.
Any other imaging which will help you in
cardiac MRI will be helpful, sir, to know the actual cause of this cardiac failure.
Okay.
And one more thing, in cardiac failure, the patient is still volume overloaded and you have saturated your doses of diuretics. Is there any other options there? Probably ultrafiltration can be tried in those situations. Okay.
So we are planning for a cardiac MRI for this patient.
How do you, ultrafiltration, Dr. Sabdish told, it may not be available in all hospitals. So what else you can do in a peripheral settings?
Diet.
Some doctors, they remove some amount of blood, okay, venous section, and they remove acutely 300 ml, 500 ml blood if there is, patient is not anemic, okay, but they are all not clear-cut guidelines, okay, but we can try in, suppose you are working in a peripheral center, patient is having good HP percent, he is going to failure, we are not able to do anything like ultrafiltration or dialysis, you can try this, but they are not indicated in standard textbooks. Okay. Any other newer drugs available in cardiac failure?
We have the dapagliflozin is there, which is basically an OHA, but it will act in the proximal convoluted tubules.
So that can be tried in patient who is having diabetes. Sacubitril? Valsartan combination. This is another combination which is available, which can be tried in a patient who is having cardiac failure, like it can prevent remodeling of the ventricle. So that is also there. Okay. So what happened to this patient ultimately?
This patient became symptomatically better. So we are planning for a cardiac MRI. We are already started her on carvedilol, sacubitril, valsartan combination, aldactone, Lasix, and dapagliflozin also.
Okay. What was the dose started? Carvedilol?
Carvedilol 3.125 BD dose was started, sir. Then Vimada 50 milligram once in a day was started, and aldactone 50 milligram once in a day.
Okay.
Along with lacilactone.
Okay. Then again, you want to start any drugs like aspirin, clopidogrel, anything?
This patient doesn't have a ACS. So
we don't know, no? We don't know whether this patient is having actually a coronary artery disease. We are not evaluated.
So we have to do an angio.
And start. Otherwise, if patient we are not doing angio, then better to put him on preventive dose of aspirin. Okay. So that has to be started. Okay. Thank you.
Oh.